maybe. And we're still starting with system of care and mental health. And we're going. I'm not going to bore you a lot with the first couple of slides, but it basically summarizes where we're at with system of care over the years. You know, this is a project that really got started in 1982 with the CAST project. And in it was about 1984. 1992, there was solidification of system of care grants, and that's how a lot of us started to know more about this. And in 1986, it was Struhl and Friedman that came up with the core principles and guidelines around it. In 2010, Beth Struhl and everyone updated stuff, and that's what you see up here is the updated definition. A spectrum of effective community-based services and supports for children and youth with or at risk for mental health or other challenges in their families that is organized into a coordinated network, builds meaningful partnerships with families, youth, and addresses their cultural and linguistic needs in order to help them function better at home, in school, and in the community and throughout life. I have not practiced my diaphragmatic breathing, so I couldn't get through that all in one. Okay, so John Vandenberg summarizes it more simply, how a community takes care of its own, and I like that. And I'm a big fan of Carl Dennis. He's not out there training anymore, but he was one of the grandfathers of wraparound. And his sentence, I think, also puts a nice touch on it. If you leave somebody out, you've already lost, but you just don't know it. Sheila Pires from NTAC and University of Maryland also has a summary in her system of care booklet. And here's just basically the common things that were pretty regularly talked about, including home and community-based, comprehensive service array, least restrictive. This whole idea that the community takes ownership and makes a commitment to youth and families, keeping them in the least restrictive environment. And this whole idea of shared governance and liability across systems, which we're going to talk a little bit more about. And this whole idea also of how do we look at a blended, braided, and coordinated funding across systems. One of the dynamics that we get into around youth that have multiple challenges, that have multiple risks, factors, is this whole idea of sharing the burden, sharing the risk. We get very risk aversive as systems. We don't want to be the person that ends up in the paper. We get that. So we need some sort of way that we agree that we're going to own all of our kids and agree that no single system can manage the multiple issues of an at-risk youth and their families alone. And we need a process or a mechanism for managing this risk, if you will, across child-serving systems. And we have a decently functioning wraparound as well as service coordination mechanisms throughout our state. We're fortunate to have the Family and Children's First Council standards and implementation throughout our, even though it's not enough, we recognize that. To do that, to share the burden, but also to up-level the needs and talk through them. We become the risk managers collectively for the community. All right, cross-system collaboration becomes a critical component of how we work together across systems. And we want to be able to bring people together that may have something different to offer than your one system can provide. Shared action leads to a feeling of connectedness versus isolation as a provider or a system. It also increases mutual accountability. We want to own this together and be accountable together. We know that we can be more successful when we work together, tie our fortunes together, but also to keep in mind each of our individual mandates funding issues, and how infrastructure impact how we collaborate so we don't get pissed with each other. All right. So understanding each system's mandates. Today, we're really going to focus on behavioral health, but Children's Services obviously has a mandate for child protection and safety. Behavioral health has a mandate for mental wellness and emotional behavioral safety, self and others. Schools have a couple of mandates, safe and supportive learning environments, free and appropriate public education, and others. Intellectual and developmental disability, supportive services that focus on ensuring health and safety, supporting access to community participation, and increasing opportunities for meaningful, probably education and employment. And then juvenile justice, mainly is charged with community safety. And so when we start to collaborate and we start to join these wraparound and service coordination meetings, we all have our area that we have to hold true to and honor, and that we can't veer too far from. And that really is the mandate. Today, I'm going to focus on mental health and some of our particular additional mandates. As soon as we get into behavioral health, mental health, we always have to talk about confidentiality and the limits of confidentiality. We also have to respect the boundaries of the therapeutic relationship. And our limits on sharing information may come across as being non-collaborative. But what we're trying to do is honor the use and the family's confidentiality. Keep in mind that, mental health providers will or shouldn't really be talking about the parents or the family members when they only have a release to talk about the youth. And yet we are always getting asked to do that. So there's all kinds of limitations, and we want to just, again, the centering part here is the youth and family. What would they be okay with? What do we have releases for? And how do we do this in the most positive way possible? I think you also need to know how mental health services are funded, because it also, puts limits around what we can do. So understanding the limitations of what providers can do based on how they're funded. We get funded in mental health through the services we provide. So unlike the school, unlike the court, unlike Children's Services, which are just funded to do the work through either federal or state dollars, we are funded through insurance dollars and Medicaid and things like that. Medicaid is the largest funder. And what is a reality, especially from a system of care standpoint, is how we pay for services has not kept up with service innovation. So, for example, many services promoted by SAMHSA in system of care are not currently named or directly covered under Ohio's Medicaid state plan or many other state plans. Some examples are parent peer support, youth peer support, wraparound, mobile response stabilization. I know the state is actively, and the current administration is actively working toward getting some of these or many of these on state plan. So I'm very encouraged by that, but it's just an example of how what we pay for hasn't kept up with the service innovation. All services rendered need to be for the benefit of the child. This can limit what activities mental health providers can deliver and to whom, okay? And so if our ask from the community is, can't you just help the parent in their mental health needs? Well, no, we can't, okay? We can work on getting support for that and making linkages and referrals, but we have to be responding through to the needs of the youth that we have a case open to. Another reality is for agencies to stay financially viable, providers have to meet productivity standards, which is the number of billable hours per week. You often hear, it's one of our unhappy realities is that, hey, I've got X amount of hours I got to get in this week. And so we focus on the hours rather than the clinical service and or the system of care. And I would tell you that the persons out there providing the service don't want to focus on productivity. They want to focus on helping. And that Medicaid and insurance pays for episodes of care based on medical necessity. And mental health is not a forever service. Like the school is really a forever service. They raise kids. Mental health pays, insurance pays for episodes of care. So I wanted you to know that as well. I also want you to know that there are certain things that we just can't do, like transportation, unless it's paid for in a different way. We can't do school observation. We can't do one-on-one in the school. Those things should be covered in a different way, maybe probably through the school, things like that. We don't cover room and board for residential placements. That's why we're always scrambling for who's going to pay for that. We don't pay for time spent attending or participating in recreational activities. These are things Medicaid and insurance companies just don't pay for, even though they might be great for the child in terms of their wellness. There are certain things that we're not reimbursed for. And I needed to bring this up in terms of others' understanding about mental health and their system of care. We have a workforce crisis. You guys know that. It's just really, really bad. And I'm going to go to the last bullet first. And no other field with bachelor's and master's trained professionals have professionals not only leaving their jobs, but leaving the field. Okay? We have professionals not only leaving their jobs, they're leaving the field. We need to fix stuff, okay? So we need to invest in resources. If you invest in resources without reward, leads to stress and burnout. That's from Stephen Hopfall. And in mental health, we have very limited, actually, opportunities for advancement within an agency. When we focus on the business of the work rather than the rewarding part, which is the clinical, that leads to burnout. So when we focus on productivity and documentation, that leads to burnout. So we have a workforce that's in crisis. So we have limitations on how many of us are out there doing the work that you want us to do. And here's just a slide on understanding the burdens of behavioral health direct care staff. We ask them to manage risk and safety of our most at-risk youth and families, manage daily ethical and crisis concerns, do work in the field, manage their own safety, do timely and Medicaid compliant documentation, meet productivity, practice to fidelity, collect and achieve outcomes, maintain positive relationships with families and system partners, and compliance to all administrative rules and standards. We ask a whole lot. And when you get trained, you don't get trained in much of any of this, actually. So we have to do this in the field. People get burned out, and they leave. The antidote is, enough, paying them enough, incentivizing them more, opportunities for advancement, enriched training, coaching, and clinical supports, and manageable workload and expectations. Okay. What are some of the services we offer? So I wanted to get into what I think we do fairly well. So a system of care-oriented mental health services view treatment as collaborative partnership with the youth and family, are available 24/7, are provided at times and locations that are convenient to the family, respond to where the needs are occurring. We always emphasize least restrictive, and the services are culturally responsive, trauma-informed, and resiliency-oriented. So when I'm looking to refer a youth and or a family, I want that service to do these things. What are some examples we have in Ohio? And this is not an exhaustive list. Well, wraparound and service coordination are really good examples of system of care-oriented services and processes. Our very newest service in Ohio, Mobile Response Stabilization Service, is an example of a system of care-oriented. Intensive home-based treatment is an example of that. And we have many versions in Ohio. We have MST, we have IHBT, we have integrated co-occurring treatment, IFAST, family-centered service, Intercept, and others. I'm sure I missed a few. Transition to independence, a model developed by Rusty Clark. This is a system of care oriented for transition age youth, parent peer support, youth peer support, adventure therapy that focuses on resiliency and regulation, and then trauma-informed treatments. So we have a number of them, but we don't have them offered enough and in a statewide fashion. This is a slide you've seen before, but again, this summarizes comprehensive system response to youth and families. So how well are we doing this? We are major up in the services component, but we also help with some of the processes to facilitate cross-system facilitation as well. This is a diagram that has been used for the multi-system youth initiatives, and it summarizes a continuum of care from anything from early childhood intervention to actually out-of-home care in residential and things like that. What we've included in this chart is not only what are the services, but what is the behavioral health promotion and supports that are needed as well for healthy functioning of youth and their families. And as you can see at the very top, you can't do all of this without coordinating all of this. And so it works best when you have a service coordination or wraparound planning process to guide the show, if you will. This is a Beth Struhl slide, absolutely stolen from her. And this just summarizes all the different services more comprehensively that are system of care oriented and actually is part of a good system of care, a continuum of care for kids. Some things that I just want to point out would be therapeutic mentoring we don't have, and actually only a couple of states have that. Intensive care management is really wraparound that Medicaid pays for. I think that's coming down the pike, et cetera, et cetera. And I know in Ohio, we're also working on crisis stabilization services and also residential. I wanted to do a quick comment on evidence-based treatments. Evidence-based treatments are a part of a system of care. And we have variable availability of evidence-based treatments. Understand that implementing these treatments requires additional financial support beyond what Medicaid and insurance pays for, because of the additional training, the coaching, the adherence to fidelity, paperwork, outcome tracking, mobility, on call, right? All these things cost a little bit more, but these all represent what you want to see in a system of care service. So how can we help in other systems? And the challenge to the other systems is to support and fund what benefits your system. And I'm going to say that again, support and fund what benefits your system. So a mental health service might benefit your system, but if we only rely on Medicaid or insurance to pay for it, we're not going to have much of it because agencies can't afford to do it. Example, MST and FFT services benefit juvenile justice and ODYS via diverting youth from further involvement in the JJ system. ODYS made a decision to support these services through BHJJ, targeting competitive reclaim initiatives. And those services get a ton of support through another system, in addition to Ohio MHAS and Medicaid. Okay, what the mental health system needs from you? We need collaborative problem solving and shared decision making. We can't operate in a vacuum. We need shared resources and supports. Your system, again, might have something to offer that our system does not. Referral to mental health does not absolve other systems of their responsibilities for the youth and family. We need a process for regular communication so that we can stay together in terms of that coordinated service delivery. And that wraparound service coordination does that. The other thing I would say is give us enough time for therapeutic effect to take hold. We need some time to do our work. It shouldn't be an immediate expectation that we got involved, things are better. We need a commitment from everyone not to give up on the youth and the family. And really importantly, to take a disability lens to emotional behavioral needs and challenges. So these are some requests we have for other systems so that we don't punish the child for their disability or punish the parent for what they can or can't do around the child's disability. And this is the last slide is something that I included in a previous presentation. I thought it was relevant. I am not going to go over it again because we're up against time. However, it's there and will be posted for you. on how we as mental health providers and other system providers need to change our practice and how we deliver services to youth and families so that it's system of care oriented. Mic drop.